Morning.
Morning, Anna.
Hello, how is everyone?
Great.
Excellent.
Good.
Can you hear me all right?
Yeah.
Cool. This is an interesting topic in that it wasn't in the textbook when I did my exams. So we're
It's trendy.
yes, very, very trendy, which is why I actually, because normally we cover a few chapters in one session, but I just thought it's probably worth spending a whole time on this one. Not because I think there's that much content in it, but just because it's like one of those topics that's likely to get examined on because it is so kind of popular to talk about at the moment.
Mm.
Has anybody come across aerodigestive disorders before?
Not as
Yes.
a term, I don't think.
Not as a
No.
term, yeah. And it all makes sense. And I think as there's a like in humans, gastroesophageal reflux and like microaspiration is a really common cause of cough. And we're only now kind of expanding our understanding now that we've got more fluoroscopic studies going on, and getting more of these kind of studies on aerodigestive disorders, understanding that that's probably a problem in animals as well. Oh no, we've lost Helen. Have we?
She's not at home. Her internet is broken, so she's out somewhere. So,
Oh. Oh, that's a shame. I was relying heavily on her to deliver this.
oh, I mean, hopefully she comes back. She did just tell us that she wasn't at home. Yeah.
Okay, right. So who's Julian? You're not sitting memberships this year, are you?
No.
No, I am
No.
indeed. Did you hear me?
No, say
Oh,
again.
I said I am indeed.
You are indeed. Okay, good. Yeah. And you're not sitting Simone this year, are you?
Hell no.
Hell no. Next year?
Probably not, because I don't have any papers written. Anyway, another story.
Oh, Simone. Um, I don't know how I can help you with papers, but uh, yeah, I've got
Think of a good
ideas for
idea.
studies.
If
Have
anyone
you
thinks
got?
of a good idea, just holler.
I would really like to know what the distribution of multi-resistant organisms are in urinary tracts of small animals in our area.
My area or your area?
Both.
Okay.
Like get like partner with Vetnostics and IDEX and just say, okay, what's like what was it 10 years ago? What was it 20 years ago? What is it now? How is it changing?
Yeah. Okay.
And you don't have to do a lot of data collection. You like get the lump of data from the lab and then you send it to the statistician and say, find the problem.
Okay. Okay. All
Um,
right. Yeah. All
I
right.
just think that would be interesting and that you could almost like copy off a paper that did it in another area. So
Mm-hmm.
that like the studies from the US and stuff doing the same thing, like what has happened to microorganisms over time. And we can't sort of say what's happening there is happening here unless we do the study.
Oh, very interesting. Okay. Yep. Good. All right.
Great. I'd like to see that.
Okay.
And then I'd like to see somebody publish all the research I did, never published. So maybe I'll just send it to you.
Look, I'm open to any ideas.
Excellent. Yeah, I do have lots of ideas, but yeah. Email me.
Okay.
Um, okay, so aerodigestive disorders. Can somebody talk us through what parts of the airway might be impacted by a digestive disorder?
Parts of the airway.
The
That's
lung
in
would
my.
be eventually, but it's at the bottom of the line.
Yeah. Tell me about the line.
And the larynx to start with,
Great. Yeah.
and then the trachea, and then the bronchi.
Yeah. We missed the top of the line.
The nose.
Yeah. And pharynx.
Pharynx,
The
basically.
pharynx, oropharynx. Yeah, exactly. So we have to include upper airway in this discussion, particularly because of the patients that are predisposed to aerodigestive disorders who are,
Brachycephalics.
yes, very good. Excellent. So predominantly patients with short noses and increased upper respiratory resistance to airflow are the patients that will end up with aerodigestive disorders. And they're also the patients who really don't have space for any more fluid or inflammation in that like upper airway. So any little increase in number of cells or edema will exacerbate the negative pressure and therefore the impact on the digestive disorder. So that interplay between that airway and digestive aspect of things.
Mm.
So tell me, if we're just talking about brachycephalics and uh, their digestive disorders, what disorders are they predisposed to from a digestive perspective?
With
Aortal hernias.
gastroesophageal reflux. Oh.
There we go again.
So you go, Simone. You go.
Gastroesophageal reflux.
Yes, excellent. So when they measure pH in the distal esophagus of these patients, it's much lower than in other patients. So they've got continual kind of reflux of gastric acid up into the lower esophagus and presumably upper esophagus as well. If there's no sphincter between the lower esophagus and upper esophagus, right? So once it's kind of in the esophagus, it's in there. What else?
Aortal hernias.
Excellent. Good. Yeah.
So probably cause between like an interplay between their like genetic anatomy and also
Mhm.
because they're like have chronic pressure changes in their thorax from breathing through their tiny airways. It's gonna constantly put pressure on that stomach to suck it up into the thorax.
Yeah.
And
Quite
then you're
hard
gonna
to diagnose, I find. Quite hard to diagnose.
It's so hard to diagnose. So frustrating.
Mm.
So I really like your terminology there, Helen, on the negative pressure sucking the stomach into the thorax, because I think it really helps with the understanding of how these two disorders go together, the aerodigestive
Yeah.
disorders. So if you like block your nose and like almost completely block your nose and then try and breathe through it and feel, I want you to actually do this, everybody, and actually feel the vacuum in your chest. Can you feel that?
Yep.
So if you've got a widened hiatus, that's going to get sucked into the thorax. And even if you don't have a widened hiatus, your esophagus is going against that negative pressure, and it's actually going to pull gastric acid up into that space or into the esophagus. So that any increase in negative pressure in the thorax from obstruction up here is going to predispose to hiatal hernia and reflux. What else? What other digestive disorders are there?
They
Regurgitation.
can have
Yeah. So yeah, regurgitation. Um,
It's not really a
There's,
disorder. It's more a clinical sign, I suppose. More a
I
sign.
know, and it's almost like hiatal hernia could cause that, and esophagitis from GERD can cause that. Yeah, so it's sort of maybe response rather than.
Mhm, mhm,
Although one of the other ones is esophageal dysmotility.
mhm.
So often they've got kind of redundant mucosa in their esophagus because they're short. And their motility is reduced. So I remember years ago, when there was like two radiologists in Sydney, and that's it, doing a fluoro study with one of them, and it was brachy, and he's like, "Oh yeah, normal for brachy," and I was like, "Where is that published?" And he's like, "Just is." And so even sort of back then when brachy weren't super common, he was like, "That's their esophaguses are just slow." So now we know that that's not actually normal, that's pathologic, but they all have it.
a hyperplastic trachea might be. Now, that's not really aerodigestive, is it?
Well, it definitely is going to contribute to the negative pressure, isn't it? So if you've
Mm.
got resistance to airflow, whether it's hypoplastic trachea or the brachycephalic airway syndrome, both can cause that for sure. The other digestive disorder I'm thinking of, and I don't really know what the link is, but pyloric stenosis or hypertrophic pyloric hypertrophy. So really
Poor
common in
gastric
brachy.
emptying.
Beg your
That
pardon?
you get delayed gastric emptying or poor gastric emptying. Is that the link?
Exactly.
Yeah.
Yeah, exactly. Yeah. So these dogs often regurgitate, and it's like a often large volume, just undigested food.
Mhm.
So they kind of, it's like a passive. it looks like vomit, but it's a passive process, so it's falls under regurgitation, but it's just due to delayed gastric empty. And I don't know what the yeah, I should have read more about this, but the pathogenesis of the actual hypertrophy, because it is acquired, they're not born with it, but it's really common in these patients, yeah, brachycephalic patients. One time I diagnosed a French bulldog, I'm sure I've told this story already, with pyloric hypertrophy, and it was so severe that we had to do a ZY pyloroplasty, so take out the chunky area and like widen up that area. And when it went off to the lab, it had
You
eaten.
did that, right, Anna?
No. Uh, when we sent it off to the lab, it had eaten like a berry with little spikes on it at some point, and all the little spikes had gone into the pyloric wall and stayed there, and that's why it was hypertrophy. It's so bizarre. So it wasn't the genetic form, it was
It was
French.
like a foreign body reaction type
Yeah,
situation.
exactly. Yeah.
Oh.
So yeah, definitely worth doing histo on these guys. But yeah, it wasn't until I sort of mentioned like, oh, there's plant matter in the stomach wall. Do you have any like plants that you can think of that might have? And they're like, oh, you've got one of those native hibiscus that have those berries in our backyard. The berries get in everyone's like skin and cause irritation all the time. It's like, wow. Yeah. Anyway, interesting. Never assume that it's genetic, but regardless, same impact on the on the airway and digestive system. Okay. So if we know, hmm, okay, so if we know that the negative pressure in the upper airways or obstruction of the upper airways contributes to all of these things, what can we do to decrease the risk of aerodigestive disorders developing in these patients?
OS surgery.
Yeah. And early, because once you've got kind of esophagitis and esophageal dysmotility and pyloric stenosis developing or hypertrophy developing, it's going to be much harder to reverse those changes. Is that going to fix all the problems, all the risk?
No.
Oh, excellent. So let's talk about individual sections of the airway and how they might be impacted, starting with the most common diagnosis, that like the most common aerodigestive disorder, I would say, which is aspiration pneumonia. So that's the most severe form, I guess, that we see and we see quite commonly. So aspiration is typically vomit or reflux. What contexts are we patients at risk of aspiration pneumonia?
If they have some sort of laryngeal dysfunction, like laryngeal paralysis, for
Excellent.
example,
Yeah. Yeah.
or you've anesthetized them,
Yeah, I was
so
going
you've
to say.
you've taken that away.
Yeah, exactly. So laryngeal dysfunction, for sure. And hey, Matt, what do we know about brachycephalics and laryngeal function?
It's reduced. They have reduced laryngeal function and impeded swallowing, and a lot of excess tissue. So there's soft palates in the way and things to structurally make it harder.
Yeah, exactly. So much more predisposed to laryngeal paralysis as a result of chronic inflammation, swelling in that area, or paresis, I should say, like often not completely paralyzed, but um, uh, is that the right word? Laryngeal paresis, yeah.
Yeah.
So glitching.
Meaning like partially paralyzed. Yeah.
Yes.
Yeah.
So then if we add laryngeal dysfunction and a predisposition to vomiting together, we can see how high risk these patients are. And then we know that they're, particularly under GA, got low pH acid often in their esophagus. and their barrier between their airway, upper airway and lower airway is dysfunctional, we can see how high risk brachycephalics are for aspiration pneumonia. While we're talking about aspiration pneumonia under GA, what are the other than being a brachycephalic, what are the risk factors for aspiration? Like,
Length of fasting.
oh, good. Yeah. I hadn't actually thought about that one. I was actually thinking more about like while they're under GA, what precautions can we
Oh,
take to
sure.
try and avoid it kind of thing. But yeah, length of fasting. Tell me more. Tell me more.
Well, I read a paper recently that was interesting that was saying that the risk was high in patients that hadn't been fasted in the first 6 hours. And then
Mhm.
there was like a sweet spot, but don't quote me because I can't remember exactly. That was like 6 to 9 hours or something. But then fasting for longer than that, the rates of regurgitation went up again, which was interesting.
Yes. Yeah.
Yeah. So I guess if you've got, I just bring that point up in practice when you know, if you've got a patient that's actually going to have their procedure in the afternoon, it might actually not be appropriate to start them from the night before.
Mm. Yeah, interesting. Yeah, absolutely, because we know that food intake is what promotes peristalsis, right? So
Yeah, so
we're
it
going to
makes
have
sense.
gastric stasis, yeah, with acid sitting in there, and like quite acidic acid
Yeah.
as well, because it hasn't been neutralized by anything that's been given orally. So yeah, that's a really good point. So duration of fasting is a factor that might predispose to regurgitation under GA. What about the actual GA factors? Like what sort of surgeries tend to reflux more or less?
This is a bit niche, but like cesarean, because there's so much pressure. Not
Oh
rare
yeah.
medicine, but I feel
Yeah.
like they're a real risk when you've got this big pregnant bulldog that's got no room for her stomach.
Yeah. And I think
Yep.
that's like most dogs on their back.
Yeah.
Yeah.
Is the kind of risk factor. So pretty much any patient where there's pressure on the stomach, any pressure where the stomach's being manipulated as well, like whether like specifically or like because you're doing a splenectomy or just right next to it or something like that, there's more likelihood of just washing that stomach contents up into the esophagus. And then
On that
um,
point, what about just obesity?
yeah, great call. Yeah, for sure. Just increased pressure on the diaphragm.
That
And
Pickwinian syndrome pressure.
what's Pickwinian syndrome?
Pickwickian.
Yeah. Big
Pick
weekend.
pick Pickwin. We've spoken about it before in the past. Just the increased pressure due to obesity, I think.
Like a respiratory pattern.
Respiratory.
It's a people thing.
Ah,
My partner's an anesthetist, but it's a fat people breathing pattern.
Yeah.
It's a big
ah,
problem in people. Yeah.
So I think it would promote reflux as well because of that pressure gradient. The
yeah,
same sort of thing as the cesarean, I would say.
yeah.
It's named after Mr. Pickwick in Oliver.
Yeah.
Oh, good trivia. Okay, so presumably if you've got increased weight on the chest, so if that's due to obesity and or weight on the other side of the diaphragm, so any kind of barrier to diaphragmatic movement or thoracic wall movement, I'm presuming that's Pickwickian syndrome, where we get an altered respiratory pattern due to essentially increased like push to exhale rather than inhale. So decreased tidal volume and stuff like that, I would assume. I wonder how that impacts, because presumably then the negative pressure in the thorax is actually reduced.
I think obese people hyperventilate because don't they tolerate higher carbon dioxide like all the time. So then your brain doesn't respond to carbon
Oh,
dioxide triggers. I think that's why that obesity hyperventilation syndrome thing is a thing.
oh,
And the physical, but like I
mm.
think it's also a brain thing.
Oh,
Like,
interesting.
which
Yeah.
would make sense that Boas dogs have too,
Mm.
because I feel like they just have high carbon dioxide all the time.
Yeah. Did you say hypoventilate?
Yeah.
Yeah, right. Interesting. And I wonder if you've got a higher respiratory rate because your tidal volume is reduced, I wonder if that almost acts like bellows, like maybe it's not an reduced negative pressure thing, maybe it's just like increased diaphragmatic movement and washing of the gastric contents around as a result of that. Don't know. Anyway, that's fun to research, but it's nice to think about the different factors that might be contributing to development of reflux. Um, the most common time for a patient to reflux under GA, does anyone know?
Production.
When they're being moved? Oh.
They're being moved, exactly.
Mm. Like you
Um,
don't pick them up, just keep them on the trolley, like all this stuff. That's what, yeah.
yes, exactly. So oftentimes we are recovering them as we're moving them back to their cage, aren't we? And we've either just taken out the tube or we're just about to take out the tube and we've got the cuff down and we lift them back into the cage. And it's actually the time where they're most susceptible to refluxing. And particularly orthopedic patients moving on and off, they often get moved on and off surgery
Oh, okay.
table,
Extra
onto
table.
radiology, back onto surgery table to close up or whatever, or to bandage or whatever, and then back in their bed. So that's a very high risk period for them. So I guess it's just something nice to put into your practice if anybody is listening and doesn't do it already, is keeping tubes in and cuffed and patients connected to their anesthetic machines, because the different ways that aspiration can occur is obviously reflux, but it can go around the tube if you've got the cuff down. It can go down and just sit above the cuff, and as soon as you take the cuff down, just run down into the lungs. So also something just to be aware of, check the larynx for evidence of regurgitation before you take the cuff down. Or it can actually go in the end of the tube. So if you've got them disconnected and they regurgitate a pool onto the table and the end of the tube's just sitting in the table, that's another way that whatever they've brought up can go straight down into their lungs. And I think it's that taking the cuff down and being aware that it's probably even just some saliva and stuff, even if they haven't refluxed, is probably going to get down into the lower airways in that period where we've essentially compromised laryngeal function on their behalf. So definitely something from a management perspective, we can reduce the risk of aspiration pneumonia. So once aspiration pneumonia has happened, or once they've aspirated, what is the mechanism of kind of pathology?
It's mostly acid damage
Yeah,
from
excellent.
infection.
Great.
Pneumonitis.
Pneumonitis, yeah, absolutely. So those lower airways, alveoli, and then the pulmonary tissue around them are infiltrated with white blood cells, edema. There's increased blood flow to those areas. Um, and increased blood flow in the lungs equals decreased gas exchange, basically. So whether it's because it's filled up the actual airways themselves or there's a increased pulmonary tissue as a barrier to gas exchange across those surfaces. So if you get a big volume of aspiration, what's your blood gas going to look like?
If it was severe enough, you could have decreased PaO2 and increased PaCO2, or even go into a respiratory acidosis if it's severe enough to lead to VQ mismatch, because you'll get bronchoconstriction of that area that's not in response to all of that inflammatory cytokines, the increased blood flow to that area, and then eventually you'll get atelectasis once the damage is severe enough to disrupt the surfactants, and then you'll get lost surface tension and lung lobe collapse of those areas.
Yeah. So on your blood gases, what actually happens is your oxygen's going to go down first, and often your PaCO2 goes down as well. Why?
Down.
Goes
Because
down.
it's exchanged more readily.
Good.
So
Oxygen.
I guess it's sitting, it's still exchanging well, but then why would it go down?
It goes down because they're trying to compensate for the low oxygen. So they start hyperventilating, don't
Of
they?
course. Yeah. Yeah,
Yes, they're
So
blowing off more.
of course.
yes, exactly. Yeah. So CO2 is exchanged much more readily than oxygen. So when you've got a barrier to gas exchange, CO2 is not affected early.
Mhm.
CO2 is affected after the oxygen in the context of aspiration ammonia.
Mhm.
With hypoventilation, we know that CO2 goes up before oxygen goes down because there's much more oxygen than they need typically to get the PaO2 to go down. But this is like that where we can kind of say, okay, this patient's on 100% oxygen, his PaO2 should be between like 450, 500 on an arterial sample. And we start to get down to like 200, 300. And that's because we've got a barrier to oxygen being absorbed into the system. And your CO2 will go down as well in that situation. So we've essentially burnt the bottom of the lungs. Then what happens? So often we don't see them with their like low oxygen level. We see them presenting to us or like developing pyrexia, don't we? With sepsis. So where does the pyrexia come from if we've kind of got gastric acid is the main cause?
It's like a bit of a systemic inflammatory response.
Yeah.
And
And
those, oh, sorry, Anna.
you go.
I was just going to say now we've got that like intense pneumonitis from the acid burn, that tissue is going to be more predisposed to having a bacterial pneumonia, which normally the body would, like that lung tissue would be exposed to that bacteria normally in small amounts, but your immune system would be able to clear it well,
Perfect.
but not
Exactly.
once it's damaged.
Yeah, so that raises a really important point that there's a very normal cycle of aspiration or inhalation of bacterial organisms and other organisms, and the mucociliary clearance mechanisms clearing them out. When we get any damage to the airways, the cilia get damaged as well. So the surface of the like airways will get burnt in the process of this, and we lose that innate immune response of being able to clear organisms from the lower airways. We also get a little bit of necrosis down there, which opens up opportunities for infections with organisms that wouldn't normally be able to set up in a very aerated environment. So what sort of organisms do we see with aspiration pneumonia if we did a culture?
You might see like normal enteric bacteria that's come from the reflux, like E. coli and enterococcus.
Hopefully it's just gastric content. So hopefully there's not too many coliforms in there, but
Okay.
you're exactly right. Often there is coliforms in there.
Klebsiella.
Klebsiella, yeah. So oropharyngeal organisms are the most common, just because that's the normal stuff that's getting aspirated that we can't then clear. So staph, strep, Klebsiella is a very kind of, it causes its own pneumonia. It's quite a pathogenic organism in itself, not a commensal. Clostridial organisms as well. Pasteurella, I want to say. And has anybody ever smelt the breath of a dog with really bad aspiration pneumonia and just it smells like dying? Have you?
Because it is.
Well, it's necrosis. Like it's the anaerobic organisms in their lungs, and it's a really distinctive smell which really helps guide you towards metronidazole as one of the options for management. It's very distinctive when you see it. So aspiration pneumonia, most common aerodigestive disorder that we're most familiar with. But then what we're coming to understand is this kind of spectrum between aspiration pneumonia, where all of those, that kind of pathogenesis of disease, like that failure of the mucociliary clearance mechanisms and things, are all happening, but on a much smaller scale, like maybe without the necrosis and without the oxygen deficit and things like that. So let's talk about Um, okay, let's talk about what we might see. Well, how would we diagnose aspiration pneumonia apart from blood gases and stuff? Like if you're not in a facility with blood gases, smell their breath.
Um, X-rays or a
Brad?
thoracic ultrasound.
Excellent. Okay. And say this is a post-op patient that you're worried about. Or no, okay. Say this is a dog that's presented with community-acquired aspiration pneumonia. What is the expected distribution of changes?
Cranio-ventral should be the worst.
Yeah, because typically they're upright when they aspirated, right?
Yeah. Okay.
Yeah. So it's gravity dependent. So where the whatever they aspirated fell is where they develop pneumonia. What about in a post-op patient? What distribution would you expect?
Maybe more dorsally if they've been in dorsal.
Yeah, it depends how they were positioned for the surgery or when they aspirated. So it could be actually quite lateralized or quite dorsal. And that's going to make it a little bit harder to pattern recognize on a radiograph and worth just keeping in mind and making sure that you're working with whoever did the surgery and saying what position were they in, where am I looking for pathology here when you're doing your T-fast and seeing, or thoracic POCUS, whatever you call it, to see the distribution of changes, like you can kind of know where to look, sort of thing. I'm gonna go back a little step. No, I'm not. Am I? I don't know. Okay. This is where I want to have this section of the conversation while Matt's in the room. Are you in the room for long?
Yeah, I just pulled up from
Oh,
daycare, so I can give you more attention.
yay. Beautiful. Okay, so there's a few different predisposing factors that we talked about as far as like brachycephalics being the most predisposed to this. But given that we said that any sort of compromise in airflow, nasal passage, pharynx, larynx, and esophagus can all predispose to, or stomach can all predispose to these conditions, it kind of, I guess we can then say that any gastrointestinal disorder which is associated with any degree of ileus or decreased motility could then predispose to these conditions. So I don't want to jump ahead to kind of treatment and management, but has anybody seen dogs with IBD or chronic gastroenteropathies with chronic reflux?
Sure.
Yeah.
So
And I think an interesting conversation is how do they present? So how do you know that these dogs are having reflux?
To me, I think it's a lot of it, from my perspective, is the IBD activity index or the enteropathy index, and just looking for the timelines of clinical signs. I mean, if there's bilious vomiting syndrome, part of it, like so the morning vomits, but to me it's often what the chief complaint that I get is 2, 3 a.m. Lip smacking, pain, restlessness in the middle of the night. That's probably like the standout complaint.
Hmm. The reason I want to talk about this is because it's something I think we don't probe for in the history often. So there's, they might not actually report for vomiting. They might sort of say chronic diarrhea, but then when you really kind of knuckle down into it, it's a poodle with a chronic cough that does this, like exaggerated swallowing often and lip smacking. What's it called when they extend their neck?
Torticollis? No.
No, I can't remember the word for it. Like it's one of the clinical signs of esophagitis, like esophageal pain when they're swallowing, they do that.
Mm-hmm.
But it's really hard to describe to owners, like, do they ever do this thing? So it can be really hard to get that history of potentially chronic reflux in these patients.
Just ask all the owners to video the dog doing anything weird so you can look at the videos.
Yes, agree. But then what if they don't think that's weird? What if the dog's always done that?
Mm.
And it's hard to catch, right? It might just be like one little swallow or something every now and again.
I'm
Um,
surprised at how much if you watch them closely in like a 45-minute consult.
yeah.
Sometimes you pick up on stuff.
Yeah, I
Yeah.
agree. Or
Especially if they're
feed them in the
fasted.
console
Oh yeah.
Mm,
Yeah.
and watch
mm,
them eat in the clinic.
mm. Yeah.
And then
Um,
nowadays, the other thing you can do is ask them to look at their CCTV from their pet cam.
that's true.
Yeah.
Well, generally my owners have pet cams, but I don't ask.
Yeah. Yeah, you see the video that they send to you. Um, so
We
that
caught a dog having her first.
first what? Sorry.
Or we caught a dog having her first seizure the other day on
Oh,
on the pet cam.
yeah, right. Yeah,
Yeah.
wow. That's lucky. Did the owners just go through the 12 hours of footage or?
She was with her.
Oh, right. Yeah, okay, right.
She
So,
had the video of it
yeah.
that we sent to the neurologist, and yeah, it was really helpful.
Oh, yeah, that's awesome. Yeah, so I think in the context of now that we know that kind of micro reflux that never actually turns into a vomit is going to impact the airway. I think the patients that we were highly concerned about, the brachycephalics, that kind of population of patients that we should be highly concerned about developing airway damage over time should be actually like quite a big spectrum of patients now. So tell me how a dog that doesn't have brachycephalic airway syndrome might develop an airway impact of their chronic reflux.
Tick paralysis.
Did you say tick paralysis?
Yeah.
Oh, that's so any patient absolutely is going to get
Mm.
laryngeal dysfunction from tick paralysis, but I'm thinking more about like really chronic reflux and how that impacts the upper airway and how that then might impact the lower airway.
Well,
Well,
the acid. Go
sorry,
on,
Jeff.
Matt. No,
Oh,
you speak.
I was going to say, like, can there be A, vagal nerve damage, and B, just that the acid actually causes perpetuating smoldering dysfunction of the larynx due to all of that edema and inflammation from the acid burn around the larynx pharynx area?
Absolutely. Yeah. So as soon as you get inflammation around the pharynx and larynx, you get disordered swallowing and you get laryngeal edema. And if the larynx is swollen, it's not going to seal as well as it should. And where are the cough receptors?
The bronchi.
There's some right at the bottom of where the trachea bifurcates. Yeah. So they're in that primary bronchi. But where are the ones that are higher up?
In the larynx, there's cough
Yeah,
receptors.
exactly. Yeah, exactly. So as soon as you get inflammation there, you actually trigger a cough. What does cough do to a lower airway, particularly when there's obstruction or swelling at the upper airway?
Puts them under pressure.
And
Yeah.
causes inflammation.
Yeah, exactly. Yeah. So you get this, even if there's absolutely no reflux getting down into that lower airway, just by means of triggering a cough in that upper airway, you're going to have some lower airway inflammation developing. And then as a pet ages, so if this is a really chronic thing that they've dealt with, these IBD dogs often present when they're 1 or sometimes younger than that. If this has been happening over the course of a lifetime, a cough, the mechanism of a cough is that the body closes off the upper airway, generates positive pressure in the chest, and then blows whatever's in the lower chest out, or like in the airway out. So that's the kind of the reason behind a cough or the way that it works. So if you've continually got chronic increase in pressure in the lower airways against a closed upper airway, so that like coughing frequently, you get damage to the lower airways, resulting in bronchiectasis. So sort of loss of that architecture and structural integrity of the lower airways, and then bulla developing chronically. So even if we're not actually aspirating anything at all, just that chronic laryngeal inflammation will cause clinical signs of cough and then lower airway chronic bronchitis symptoms.
Mm.
But once the larynx is edematous and the function is reduced, and then swallowing presumably is also compromised, we are going to get microaspiration developing as well. So we're then going to perpetuate that scarring, damage that mucociliary clearance mechanism, and mean that these patients that we've, particularly the oodles and stuff, prone to IBD, also prone to chronic cough and bronchiectasis, aren't they? Oh, I wonder if they go together. Yeah, and we get that loss of mucociliary clearance mechanisms. We get increases in presentations of pneumonia because they can't clear bacterial infections. And we get this kind of dry, honking cough, often associated with loss of cartilage function in the airways. But we don't know what the relationship to that has to reflux. Like, could most of these patients or some of these patients actually have bronchiectasis from chronic cough, from chronic reflux? It's
We don't
interesting.
have another good explanation for chronic bronchitis, so it's worth considering.
Yeah, exactly. Yeah. Why do they develop it? It doesn't, yeah. I mean, dynamic airway disease for sure, but then like dynamic airway disease, if you put cartilage under that much pressure, if you've got a chronic cough, cartilage under that much pressure will bend. It will become soft. It will lose its structural integrity. Anyway, interesting thought. What about patients? We've talked a little about compromised esophageal motility in brachycephalics. What other patients are predisposed to compromised esophageal and laryngeal function?
Well, myasthenia gravis was coming to
Yeah,
mind.
for sure. Yeah. Obviously not the nice thing, but as far as how that's going to impact the airways chronically, it's quite a short-lived condition typically. Why is it short-lived? So average survival of a patient with myasthenia gravis is less than a year, I think.
Mm.
What do they die of?
I don't know, do they die of a severe aspiration event?
Yeah, typically. Yeah.
Yeah.
So they usually either get sequential aspiration events and the owners run out of money and ethics of wanting to put them through hospitalization again, and they have to make a call to euthanize them. So myasthenia is probably a less common cause of esophageal and laryngeal dysmotility. What's more common?
What about just like old dog laryngeal paralysis?
Yes, caused by.
Not a neuropathy.
Yeah, exactly. So often they've got esophageal dysmotility as well as laryngeal because it's a polyneuropathy. It's not just a neuropathy of the recurrent laryngeal nerve. So they often go together is we get patients with compromised laryngeal function as well as compromised esophageal function. So particularly in those kind of old Labradors where we know like you can hear them breathing, right? They walk in, you're like, whoa, okay. The type of food that we're feeding them, we tend to like sort of say meatball style food so that it doesn't crumble above the larynx and go down the wrong way. But you're actually helping with esophageal motility as well in the process of doing that. So instituting some of the strategies that we use for myasthenia gravis, Jeff, like the kind of at least getting them to sit and using a little bit of gravity to help with food going down the esophagus, might decrease the incidence of reflux and things in them as well.
Anna, there was one condition that I saw in Adelaide, which is more than 10 years ago. I've mentioned it before, and I've only ever seen it once, and that was a right-sided heart failure in a 9-year-old Frenchie.
Mm.
And my assumption was that due to chronic lung damage, the heart, we had, what's the term for it? Cor pulmonale.
Yeah.
I mean, it's not written up as far as I'm aware, and you thought at the time that it was unlikely.
Mhm.
and one case proves nothing, but people were looking out for it. They'll probably find it if it exists as a problem.
Yeah, for sure. We definitely see most common cause of right-sided congestive failure other than left-sided congestive failure. So we get left side venous congestion, chronic pulmonary edema causing right-sided cardiac failure. That's most common. But second most common is actually lung disease. So causing like infiltrates of inflammatory cells, changes in the um, like remodeling of the arteries as a result of that causes pulmonary hypertension, puts more pressure on the right side of the heart. They develop pressure overload, then they develop volume overload, and then they go into right-sided congestive failure. So that's absolutely a sequelae that we see in dogs with chronic bronchitis for sure. And we're saying that this is linked to chronic bronchitis. So absolutely, we could see that. The other thing with Frenchies is they get pulmonic stenosis very commonly.
Yeah,
So that's
I mean, it's more than 10 years ago, so I don't really remember much about it now. Heartworm would be another thing that could cause it, but that's not common now.
no, exactly. And not linked to digestive disorder either.
No.
Um, okay, so how are we going to, what sort of questions do we want to ask our clients to determine whether an aerodigestive disorder might be present?
Yes,
Well,
sorry, you go, Matt.
no, you go. All
No,
good.
honestly, I was just going to say, if they present with one sign, like presenting for a chronic cough, careful questioning about gastrointestinal
Great.
clinical signs,
Yeah.
ranging from appetite, vomiting, diarrhea, behavior after meals, behavior overnight, like Matt suggested, the lip smacking, all of those signs, even if they're presenting for respiratory, and vice versa, they might present for vomiting and then have forgotten that they've got a chronic cough because they're so used to listening to it and don't really
Yeah.
mention it.
I think that's a really good point. Any chronic condition, and particularly the dogs that might have had like a little bit of reflux over a lifetime, that's normal for the owners. Like we have to ask very specific questions for them to go, oh, they do actually do that. Is that not normal? I don't live with any other dogs at 2 a.m. So very specific questioning, and like Simone said, videos are so helpful. But yes, I think that shift from mindset around I am investigating a respiratory disorder to I might be investigating a gastrointestinal disorder, which is contributing to respiratory dysfunction, is really important. Then,
That point, so I
yeah.
just jump in on that because another thing, and I'm actually thinking about a client, Anna, that you may have known, her last dog that had laryngeal paralysis. She was describing, she's like, oh, my new dog drinks water really funny. He like sticks his neck out funny when he drinks water. I think that's probably another line of questioning as well as around, or like just watching them drink, because
Yeah.
I know humans with like say like motor neuron disease and other neuropathies, like they use like how they drink water liquids versus solids as a gauge of like which diagnostic path to go down. Dogs have that drink water in a funny way or have any sort of like dysphagia is another question. So to Helen's point, I was going to say like yeah, like question the comorbidities around the gut, the chronic enteropathy. And the other
Yeah.
one, I don't know if you see it more with the reflux, kind of silent reflux pattern, but the dogs that have more borborygmi, perhaps obvious diarrhea, like that's some people say like, you know, I can hear my dog from across the room, but they actually never really have diarrhea or vomiting history. And so they're dogs that I think are also like kind of underdiagnosed enteropathies.
Yeah. Burping as well. Like it's not normal for dogs to burp often, I don't think. So any dog that's burping a lot, I would say there's probably some sort of motility dysfunction in the gut, and therefore they may be more susceptible to reflux. And I've had several clients with patients with IBD who've reported like a metallic smell on their breath, and I would say that's bile. Yeah, because I've looked extensively by endoscopy in these patients for ulceration and bleeding, which is what I thought it might be. But I would say if they're smelling bile, it's like it's in the esophagus. It's not just confined to the stomach. So that's another thing. Like, does your dog ever burp in your face and does it smell metallic?
So specific.
And then the other thing apart from the gut is also like from a dynamic airway disease point of view, I don't know if this would show up with these chronic microaspiration events, would be whether we get ALT induction
Why? Why would we?
from a hypoxia. Like so, like if you have really bad dynamic airway disease, you can get liver enzyme elevations as like a
Yeah.
sign that would be a candidate for stenting if it's possible. Would you potentially see that as part of this constellation as well from I think it's a hypoxic mechanism.
So I would say ALP is typically the liver enzyme that's elevated in the chronic bronchitis dogs, the chronic airway disease dogs. And nobody really knows, to my knowledge, what the mechanism of that is, but it's thought to be associated with either chronic stress or chronic congestion, rather than hypoxia.
Okay.
If they were to, so typically the cause of hypoxia in the liver is actually circulatory, so it's decreased blood delivery rather than decreased inspired oxygen. And I think we'd probably get if it was decreased inspired oxygen, I think we'd get syncope, vagueness, behavioral change before we got, I mean, the ALT would go up to if we were chronically hypoxic. But because it happens quite slowly, and we're not talking about a big aspiration event, talking about more kind of chronic damage, I'd be surprised if they were hypoxic or hypoxic to a level that they haven't compensated. Yeah.
Yeah.
But interesting,
Yeah.
I think the ALP thing, like I think we're going to see those things hand in hand for sure, because we're going to see the chronic reflux, chronic aspiration,
I mean,
chronic
that'd all be
bronchitis.
like that's old dog chronic. You could easily be like, that's old dog lungs, that's vacuolar hepatopathy all happening in the same patient due to
Totally.
yeah. Never
Exactly.
really. The other one, if there's micro events, this is something that we do in our practice quite a bit, which is adding a CRP to a screening total practice. So watching baseline CRPs, like not looking for a CRP of 30 or 100, but actually looking that it's been like between 2 and 4 for 5 years, and then it spikes to like 8 or 11. To me, that's when I'd be like, okay, where is the inflammation?
Yeah.
So
Which lab do you use, Matt? We just get less than 10.
You get less than 10?
It just says less than 10 if it's less than 10.
I use IDEX.
Okay.
Yeah. No, less than 10 is not useful for me. I mean, it's obviously useful in a setting.
Yeah.
But no, IDEX.
Okay, well, it's possible. Okay, yeah, all right. Okay, sure. Yep.
I think that's a really good call, and I think that's a really good example of responding to the direction that clients want us to head as far as the way we're managing their pets. So I think we as vets are kind of used to putting out fires and keeping animals well in the short term, but I think there's much more of a push as owners become more aware of their well-being chronically and their inflammation levels impacting their well-being. I think we're going to have that same kind of trend emerging in dogs, and to have a CRP attached to every profile, it's not a huge cost more, but those owners that are doing the annual health profiles, they're the ones that will jump to attention if you say, okay, it's jumped by 10. It's probably worth looking into what's causing the inflammation in this setting. So I think that's a really good strategy. If I was seeing patients chronically, I would absolutely be doing that as well.
The liver enzyme elevation you referred to, Matt, was that ALT or ALP?
My brain said ALT, but actually when I think about the dogs, I was more thinking of like bad dynamic airway disease dogs who I think have, from my memory, they could have ALT and ALP, but if Anna's saying it's that the patch is more ALP, I would defer to her on that. But yeah, I was just thinking if we saw anything there, but I agree that unless it was from a gut liver accident perspective,
we're losing you, Matt.
including the liver bile and the esophagus or wild. I don't think. I think it's probably not related in these chronic aspiration cases.
Let's just use the last 3 minutes just to talk about therapy. So if we have a history that's really consistent with chronic reflux, chronic microaspiration, and chronic cough, if we've kind of got that constellation of signs, what are our options for medical management for this patient?
Well, reduced gastric acid would be one of them.
Yep. And what would be the best option for that?
Forgot.
Omeprazole.
Yeah, exactly. Yeah. The downside of omeprazole,
And
sorry.
I didn't catch what you said, Simone.
Omeprazole.
Oh, yeah.
Yeah. So omeprazole, we know that it reduces gastric acidity, so it increases the pH in the stomach. The downside of that is that then that acidic tide that we kind of rely on for population control of bacteria in the proximal duodenum is lessened. So we do alter the microbiome by using omeprazole, and it may be the lesser of two evils. It may be a requirement, like this patient might require that to maintain their airway, particularly in the brachycephalic patients where they just don't have reserve for any increased edema in the upper airway. But I think we should look at accompanying omeprazole with management of the microbiome to try and stabilize that as best we can. So certainly probiotics in these patients. This is not, none of this is evidence-based. It's too new to have evidence on this, but we do know, particularly in dogs with IBD, that probiotics, IBD and chronic enteropathy and stress-induced diarrhea, probiotics decrease clinical signs. Also diet like that manages prebiotics. So Matt's definitely the expert on that topic.
on the probiotics, there's also more SIBO-safe probiotics, so probiotics that don't less likely to colonize the upper GI. So Bacillus coagulans, BC30, and Saccharomyces boulardii would be a better idea for a dog that had upper motility issues on PPI. I would put them on 2 probiotics if they're on PPIs.
Yeah. So I think that's a really good point. So where you've got bacterial overgrowth, adding more bacteria to the mix is not necessarily beneficial in all situations. And whilst I think a lot of our patients are trial and error, I have where I've been suspicious of SIBO. So for example, if they've got an elevated folate level, I will sometimes reach for the Saccharomyces based, like Matt said, probiotics, the yeast based probiotics, because they're going to compete for nutrients and things at that location, decreasing the number of bacteria in that proximal duodenum just by competition for nutrients without necessarily increasing bacterial numbers in that area. In fact, decreasing bacterial numbers. That's the theory, but it doesn't work for all dogs, obviously. But we have had a few that I was like, oh, that's an interestingly positive response.
Anna, can I ask an omeprazole specific question? Actually, two. One,
Yeah.
if you haven't referred your patient for like a dynamic airway study, you're just really suspicious of this from history and physical exam, and you want to do an omeprazole trial, how long do you think is reasonable before determining whether it's effective or not in management with their underlying gastrointestinal disease and other management strategies to trial omeprazole for? And B, how long do you have them on it before trying to wean them off it, if you do ever try and wean them off it once their underlying GI disease is managed?
Yeah, good question. So how long does omeprazole orally take to work until you actually see a reduction in increase in gastric pH?
Like 3 to 5 days for maximum effect.
Yeah, exactly. It's really slow. So you can't just do a week trial because you're only just getting a normal or an increase in the gastric pH by the time you're taking them off it. And what we are going to be looking for is a reduction in incidence of cough and clinical signs of like lip smacking and stuff like that. So we need to wait for the gastric pH to go up. Then we need to wait for the inflammation to go down. Yeah. So we're talking about 2 to 3 weeks at least. And then we can't just stop the omeprazole at that point because they're going to have a hyperacidity overswing. We need to wean if we're going to try. So I would probably say 3 to 4 week trial. And then I would be really trying to focus. I don't like doing multiple things at once because you don't know what worked and what didn't. But then if we get them stabilized clinical sign-wise on omeprazole, I would then try and stabilize the underlying motility disorders if that's an option, if they've just got a really crowded airway and a hypoplastic and a dysmotile esophagus. I would say that's going to be a problem. But the other clinical option then, if that's worked really well, is something like cisapride. So you're then addressing like the kind of impact of the gastric dysmotility in improving that. You're increasing lower esophageal sphincter tone to decrease the incidence of reflux as well. And then I'd probably try and wean them off omeprazole, but I probably would do that, then cisapride, then wean. Yeah.
I can't for the life of me remember the name of the drug, but it's an older antiemetic that increases gastric emptying.
Metoclopramide.
Yes.
But
Would that be useful?
Cisapride's
Not
meant
as
to be better,
effective.
is it?
Beg your pardon?
Cisapride's meant to be better than
Cisapride's
metoclopramide.
better.
Yeah,
Yeah.
yes, it should be.
Yeah.
And
Particularly, we didn't talk a lot about cats, but brachycephalic cats get exactly the same thing. They just don't cough
Interesting.
much.
Do you think it's, I was going to say, do you think it's recognized even less? I think it is.
Even less. Yeah, for sure. Yeah.
I seem to remember
Cisapride's much better for cats.
reading that chronic use of omeprazole in humans, like 9 months or more, often causes pneumonia, inhalation pneumonia.
Oh, right.
They
Yeah.
also worried about neoplasia in people on really long courses of omeprazole, right?
Yeah. Yeah, absolutely. Yeah.
And that for
Okay.
cancer. It's not even that long for cancer.
Yeah. It's definitely not a drug that I like using chronically. If we can manage the motility rather than the acidity, that's my preference.
And have a look at, I've used melatonin for lower esophageal sphincter and moved dogs from PPIs to melatonin
Right.
with good success too. So you can have, that's another one to that I think
Okay.
might be used increasingly.
Yeah. Interesting. All right, we're gonna have to wrap up.
thanks,
Thanks,
Anna. That was
guys.
great. That's very
Yeah,
helpful.
See you
really
soon.
good.
Great to
Have a good day.
Thanks, Matt.
Thanks, Anna.
Bye, guys.
Bye.
Good. Thank you. Oh, Anna, stay
Yeah.
there if you would. Just
Yeah.
I've got a question about other things.
Oh, yeah. Yeah.
Our Lions meetings are on second Wednesdays of the month.
Oh, yes. Yeah.
And I've got to speak to the president to see if we can fit it in, but do you have any that you're available and not available?
Yeah, so I'm just on the road on Wednesdays, but it's just by appointment, so I just block off whatever appointments I can't do. Whereabouts do you meet?
At Magpies, Waitara.
Waitara.
Yeah, the club there.
Okay.
Just right opposite the station.
Yeah, so just let me know a date, Jeff. If you can give me like 3 weeks notice, that would be amazing, just so I can block the schedule before it fills up.
Right.
But yeah, if they agree to have me come and let them know what we're up to, that would be amazing.
Yeah. Could you just give me a brief rundown on what you're up to?
Yeah, no, that's fine. So we've started a charity called For the Love of Dogs Academy. And we're working with people. We've got a doggy daycare and a grooming service, and we've just got DA approval for a vet clinic to go on site as well. And we're working with people with disability to train them for jobs in animal care. So they're getting work experience on site in kind of very kind of sheltered environment in a variety of different roles in animal care. And then we're sort of working with them on their goals and supporting them through an animal care certificate at TAFE, and then pairing them up with places to work their way into open employment with a little bit of support from us, but then with the view of them working independently within the team.
Yeah, I think that sort of thing, like the animal charity wouldn't work too well with lions. It'd have to be human, but
Yeah,
that's
it's
very
different.
human, and I could see perhaps there'd be some call for that. And
Yeah.
no, that sounds good. Where is the clinic going to be?
It's North
Geographically?
Narrabee.
Right.
Yeah.
Yeah. Okay. That sounds great, actually. I'm sure Lions would be interested in that.
Cool. Okay, amazing. Thank you.
Yeah. Okay. Very
Yeah,
good.
keep me posted.
Yeah, I will.
Thanks, Jeff.
Okay. Thanks,
See you
Anna.
soon.
Bye.
Bye.